Well, thanks for having me. It's really lovely to be here speaking to everyone. Um, I have to say, so I started at Guy's in 2013, and I hadn't even heard of eosinophilic esophagitis, never mind learn how to pronounce it. Um, and so probably in my first year, I probably saw maybe 2 patients with EoE, so really not very common, and that's grown over the last 7 or 8 years into probably 1 or 2 patients a week, and it's been really lovely to see the service expanding and being able to help so many people, and hopefully we can help to kind of spread the knowledge and help more people. I appreciate that not everyone has access to a service like ours, so it'd be good to kind of speak to some of you and find out some of the challenges that you might have afterwards. But so first of all, I know probably quite a few of you will be familiar with EoE already, but some of you might not. So I just wanted to spend just the first section by just giving you a bit of background or a bit of a recap. So this is the latest definition of EoE, and there's lots of different aspects to the definition. So first of all, it's a chronic, so a long-term condition, and localized specifically to the esophagus, and it involves the immune system, so it's immune mediated. And then there's 2 aspects to the definition. So it's the clinical side of symptoms related to the esophagus not functioning properly, but also the histological side. So what we see on the biopsies and the tissues, and we see eosinophil predominant inflammation. And the prevalence is about, this is slightly old data, but 50 per 100,000 or 1 in 2,000 people. So it is a rare disease, but not, a disease that lots of people haven't heard of, but actually the incidence is actually quite similar to Crohn's disease, which a lot of people have heard of, and it does seem to be increasing. So I've just put 1 reference here, but there's lots of data out there showing that the incidence is increasing, as with all different allergic type conditions like hay fever, asthma, and eczema. And one thought is that the reason it's increasing is because we're learning to recognize it more, and there's more endoscopies, more awareness of it. But the data out there does show that even despite accounting for those factors, it is on the increase. And so I've just presented some of my results from when we did a review of our cases at Guy's. So we had 100 patients that we looked at, and this just reflects some of the common characteristics that you see in patients in other centres. So 3/4 of our patients were male, which is really very typical what is described in a lot of studies, and the vast majority of them were Caucasian, again, very consistent with what you find in other centres. And that's these 2 factors are showing there's genetic things going on there. Our patients were a median of 35 years, and a lot of these patients we think had EoE for quite a long time and had quite delayed diagnosis. And then typical symptoms in our patients were dysphagia or food impaction. We did allergy testing in 63 of these patients, and we found a very high incidence of positive tests to food and air allergens such as pollens, dust mites, pets. And when we talk about these positive tests to food, they're not necessarily presenting with symptoms of immediate allergic reactions to food, but getting lots of positive testing. So showing that there's a strong allergic component to these people. And then 75% also had other atopic conditions such as hay fever, asthma, and eczema. And this is really similar to what's been described in other studies. So the diagnosis is made, first of all, by looking at the clinical side, so the symptoms. And the symptoms that we tend to see in adults, so this is specifically to adults, are dysphagia, so difficulty swallowing, food getting stuck, regurgitation and vomiting, and then heartburn and reflux. So that's the first thing we think about when making a diagnosis. And then the second thing is the esophageal biopsies. So we usually recommend taking at least 4 to 6 biopsies from different locations to correctly identify and pick up EoE, as it can be quite patchy. And then our histopathologist will look at the biopsies under the microscope, and they're looking to count the eosinophils, which show up as this little pink dots in a high-powered field area. And so eosinophils are an inflammatory white blood cells. They're involved in the reaction to infection and allergic reactions, and their presence leads to inflammation and chronic changes. So what we see is furrows first of all. So these can be visible on by the endoscopy. So furrows are lines going downwards, which are a sign of active inflammation. And then you can see exudate, so white patches, and these are little clusters of eosinophils. And then over time, this leads to scarring. So the chronic inflammation there for a long time leads to scarring, which can cause narrowings and this characteristic description, which is the kind of circular ring appearance. So normally the esophagus is quite smooth, but with EoE, we see the formation of these concentric rings, which is sometimes called trachealization because the esophagus starts to look a bit like the trachea or the windpipe, when it should normally be, like I say, nice and smooth. And then the last thing that we sometimes see is a lovely bit of food stuck in there. So that's a steak. So foods that typically tend to get stuck more often than others are things like kind of meat, steak, dry chicken, but sometimes things like bread and thick chips and things like that are just more physically difficult to swallow. So what are the different management strategies? So first of all, we call them the 3Ds, so the drugs, diet and dilatation. And I'm not going to talk about the first two. Obviously, we're all interested to hear about the diet side today. But the main drugs that we use are PPIs and swallowed steroids, so Flixtide or the more recent Jorveza. And the goal of these drugs is that they treat the inflammation from the EoE and then therefore improve the symptoms. Dilatation might be needed to stretch the esophagus if there's a stricture, and that will help to improve symptoms. And then for the diet, there's three main approaches from the diet side. We've got targeted diets using allergy testing to guide the intervention. We have empirical elimination diets using just the most common food triggers that from experience we know affect people. And then lastly, the elemental diet using amino acid based formula. And I'll talk about each one of these approaches individually and look at the evidence for them and some of the challenges. But first of all, just to mention that the goal of any intervention for EoE is to actually identify the underlying food trigger. So for many people, there's an allergic component. So it's a delayed allergic reaction to food, and through the frequent exposure to large amounts of a specific food, that this causes a delayed allergic reaction that attracts these eosinophils, that leads to the inflammation, that leads to the symptoms. So whenever we do any elimination diet, the idea is to identify the underlying trigger so that we can remove that and improve the condition. So it's not always a permanent restricted elimination diet. So any diet that we do should be followed for a minimum of 6 weeks, because it can take that long, and in quite a few cases longer than that, to see a full resolution. The post-elimination diet is essential. So we know that you can't rely on symptoms. They're not enough to test whether there's been a response in the tissues. And so we see both sides of it. We see sometimes symptoms get better on a diet, but we know that the inflammation is still very active. And that might be because we've got part of the picture right. We may have taken out one of the right foods, but there's still another food that's affecting the individual. And we also see the opposite happen. So sometimes we have got the diet's worked, there's no more inflammation, but you can still be very symptomatic. And that might be in particular if you've got some scarring and some narrowing that is restricting your food intake, and that can get better with dilatation. So that's why the biopsies are so important to assess if the diet has worked, as horrible as they are. And each food group should be reintroduced separately for at least 3 to 4 weeks. And I mean, the exact duration of reintroduction is a bit contentious, but this is what I advise, 3 to 4 weeks. And that's because it can really take, so most people will not react to the food very quickly. It's a very delayed build-up effect. So we need to introduce the foods very slowly. I used to introduce foods over 2 weeks, and I over time realized that that's not long enough for everybody. So we want to make sure that we're actually capturing what the correct trigger for people. Otherwise, it comes unstuck a bit later. And then finally, long-term avoidance of the food trigger is required. So to maintain that response. So if you start eating the food again, the symptoms and the condition will recur. And that's a really important thing to think about if you're wanting to undertake an elimination diet is, are you committed to doing it in the long term? Because if you aren't, that whole exercise is fairly pointless. It's just a kind of a restrictive, difficult thing to get an answer that is not going to be that useful. So the first elimination diet that I'm talking about is the targeted elimination diet. So this uses skin prick testing or a specific IgE testing, so blood testing, or sometimes patch testing as well. And the idea is that by doing these allergy tests, we can identify the food or foods that are driving the EoE, and then we can eliminate those and see a good result. So the pros are that if we can nail it with one go, we'll know where the foods are, we'll only have to do one endoscopy, and then it will all be over. However, our typical allergy tests like skin prick tests, specific IgE tests, so they're looking at an IgE response in the skin or in the blood. And IgE antibodies are involved in immediate type food allergies. So someone who has anaphylaxis to peanuts will have a high level of specific IgE to peanut in their blood, and that mechanism happens very, very quickly. And we know that EoE is a delayed mechanism with the food allergy. Also, what we do see is that the reliability of allergy tests is variable even for people with immediate type food allergy. So, and that's because you get false positives to certain foods. So you can see that what I've put here is this is the molecular structure of a birch pollen, and then protein, and then there's a cherry next to it. And even without having any knowledge of like molecular structures, you can see how similar they are. So it's very common for people with birch pollen allergies, so tree pollen, to test positive to certain plant-based foods like cherries, but also things like nuts because they grow on trees. And that doesn't mean that you're allergic to those foods that's so similar. It just means that your body's very good at recognizing foods that are similar because they've got a very similar structure. And that means that when we do allergy testing, we'll often find foods that are positive for people, and it's complete. It doesn't necessarily mean anything at all. So do targeted elimination diets work? So there was a very good meta-analysis that was published in 2014 looking at all different elimination diets. And it's a meta-analysis pulls together all different studies from all different places and groups them together and pools their results. And this study concluded that overall targeted elimination diets were 45% effective, although this was much lower in adults and there were far fewer studies. But the quality of the evidence in these studies is really quite low, and that's because a lot of the studies were looking back at the past and just looking at what people had done and what had worked, and rather than being a robust kind of prospective study where they design an intervention and then compare them together. And we also found that there was quite high variability in methods between the different studies, and that's because all different people were using all different methods of allergy testing. So some use just skin prick tests, some use blood tests, some use patch tests, and also the way that people interpret them can be quite variable. So different cutoff points, looking at things from a different angle and interpreting them and giving advice in a different way. There's no kind of standard approach to doing a targeted elimination diet. So overall, we do not recommend this approach. Sometimes allergy testing can be quite useful for people with EoE, particularly if you've got other things going on, like if you've got hay fever, if you've got other food allergies that are immediate type food allergies. They can be useful, and it can help us to differentiate what's going on to manage those other conditions. So we used to do a lot of allergy testing, as I presented at the beginning, in a lot of our patients, and we're doing it much, much less now. We found it didn't work very well for guiding interventions. The other area that they the allergy testing can be useful in is to predict people who might be at risk of having more severe reactions if they've avoided food for a long period, which we do occasionally see for some people. So that's when we might consider doing them. So what are the common food triggers? So that leads us thinking about, like, well, if targeted elimination diets don't work, what other approach can we take? So this is based on our cohort of patients from Guy's, the same patients. So when we reviewed our 100 patients, we had 14 patients who'd conclusively identified their food triggers. And the number one trigger for 8 of these 14 was milk. And then you'll see this replicated in a lot of other studies. The number one trigger is often milk and dairy foods. For us, this was followed by wheat, rye and barley, egg, a smaller number to egg, and then just one of each to soy, nuts, legumes, crustaceans, and fruit. So if you look at all these different numbers, if you add them all up, you'll notice that this doesn't add up to 14. So at the bottom, these are the 5 people included in the 7%, because they each had one trigger. So, and that's because a lot of people have more than one food trigger. So for our cohort of patients, 50% just had one trigger, then 30% 2, and then 20% 3 or more. So, and based on knowledge of common food triggers, this led researchers to develop the empirical approach, so just taking out common foods and seeing if that would help to treat the condition. And so if we were going to just pick one food to take out, if we just had one shot at it, we'd say take out milk. That's by far the most common approach. It's going to be the most common trigger. If we're doing 2, we're going to add wheat. If we're doing 4, we're also going to add egg and soya. And then if we're going to do 6, so the classic SFED, 6 food elimination diet, we're going to also add fish and nuts, although it ends up being more than a 6 food elimination diet because we're also taking out shellfish and peanut as well. And then sometimes also rye and barley. So it ends up being more than 6. And in terms of the evidence, so there is strong evidence that the more foods you take out, the more chance of success that you have. So the same meta-analysis in 2014 found that on average it's 70% remission in the tissues with a 6 food elimination diet. And obviously if you're looking at a 2 or a 4, it's going to be less successful. This specific study didn't look at the others combined together because there wasn't enough evidence at the time. But since then, there's been a large study in Spain and Italy looking at what they call the step-up approach. So starting with a 2 food elimination diet. So they put everyone on a 2 food elimination diet of milk and wheat. And then we're interested because we're looking at adults today, we're interested in the middle bar, the grey bar. So 44% of adults responded to a 2 food elimination diet. So although, like I said, on average, at least 50% of people have dairy as a trigger, you won't get a 50% response rate if you just take out dairy because often there's other foods involved as well. So 44% responded to the 2 food. So, and then of the people who didn't respond, they said, okay, well, we're now going to step you up to a 4 food elimination diet. So they also took out egg and legumes. And then when they pulled the results together, that equated to a 60% response rate for a 4 food elimination diet. And then they stepped up again to a 6 food elimination diet and had pooled response of 80%. So their conclusion was, I can't see this because it's hidden behind the people. I'm going to move everyone. It says they concluded that you save 20 to 30% of endoscopies with this approach. So if you do a standard 6 food elimination diet and you're doing your biopsy and then you're introducing and biopsying after every food group, then that's quite a lot of biopsies. Whereas if you do the step up approach, that saves quite a lot of time for some people, not for everybody, but for some people, and it can save those biopsies as well. However, there are some things to think about with this. So this is just the summary diagram of the 246 study. So they put 130 people with EoE through the study. But one thing to think about, which I found very interesting from reading the paper, is that they actually offered the intervention to 220 patients, and 90 of them were not interested. So that's 41%. So that tells me straight away that this type of approach is not right for everybody. So they, like they say, found just over 40% of people got remission from the 2 food, and then stepped up the remainder. But what I also find very interesting is that of those 74 who didn't respond, 28% did not want to continue stepping up. And then when you go to the next level, 17 people of the 44 who didn't respond to a 4 food elimination diet did not want to go to a 6. And that number has increased to 39%. So this was quite telling to me that if we keep doing lots of different interventions, that you will start to lose motivation for continuing if it is not successful. So some of the challenges of this approach is, so as I'm sure of lots of you do know, eliminating foods is burdensome and affects our quality of life. Food is a huge part of all of our lives. And so the diets are restrictive. It affects your school, your work, your ability to eat out and to socialize. So food is an important part of a lot of events that we go to. Eating out is not just a function, it's a pleasure. It's something that is maybe not so much at the moment, but usually it is something that most of us do fairly frequently. Also, the cost of free-from food. So gluten-free, dairy-free foods, they are significantly more expensive than other foods. And that's because they do actually cost a lot more to make. So they need to be manufactured very carefully away from other foods. They need to be tested. So they're often made in smaller batches. And that does unfortunately increase the cost significantly. Also, just the increased time it takes to prepare foods, read food labels, shop, think about food, do meal planning can be a burden as well. Also, I appreciate the lack of dietetic support. I'm obviously kind of biased in my own area. I know that I'm able to offer good support to my patients, but in lots of areas in the country that's not available, and so makes it a bigger challenge. Also, some controversies. I like to be controversial and talk. Lots of controversies in EoE. People have different approaches in different places. So, do we need to avoid wheat or all gluten-containing cereals? This is different in different countries. In the US, you'll find people more likely to just say just avoid wheat, whereas we do tend to say avoid all gluten-containing cereals. So, particularly like from an allergy background, I know that they're so similar, and so in our patients we do advise avoiding them all. And another different approaches, so in Spain and Italy they will say to avoid all legumes, so not just soy but chickpeas, lentils, beans on a 4 and 6 food elimination diet, whereas over here in the States that's not such a typical approach, and that's partly based on the kind of typical foods that in the diet in different countries. And how strict do you need to be? Do you need to avoid all traces of foods? Do you need to is it okay if you have a little bit now and again? That's a big unanswered question, but really I say be as strict as you can to get the best result. Do we need to avoid may contain foods? That is a big unanswered question. People have different ideas about that. Do we need to do 6 weeks for the diet? Do we need to do 12 weeks? I think doing it for longer than 6 weeks, and particularly if it's a 6 food elimination diet, can be a challenge. But the longer you do it for, the more chance you do have of success. And should the reintroduction be 2 weeks, 4 weeks, 12 weeks? Again, it's a bit of an unknown. I'm just moving on to talking about the elemental diet. So this is the third approach for diet and the most difficult by far. So an elemental diet is made up of just amino acid based formula. So no food allergens and no other food and drink is allowed apart from water. Some people, when they do it, do allow things like chewing gum or tea, or in some of the American pediatric centres, they might allow 1 or 2 fruits, but we tend to be quite strict with it just so that you get the best response. And does the elemental diet work? So it is highly effective. So it's the most effective intervention in all the research that's out there. However, it is extremely difficult. And if you look at all the different studies that have been done, there's very high dropout rates. People struggle to complete the course. And so these high effective rates are just in people who've been able to do it. So it's highly effective if you can do it. But there's many challenges. And some of these challenges are, for instance, the taste. I don't know how many of you have tasted these formulas, but the amino acids give it a really quite a bitter taste, and so it's not very palatable. Also, you may need to have very large volumes to get your calories in, particularly if you're a very active adult. And so weight loss is common because of this, for this reason. Also just the acceptability and practicalities of it. It's, you know, needing to carry things around, you know, it's also the impact on socialization because of, you know, inability to just go for a drink with someone, you know, you can't even have that. So it takes a lot of motivation. And also the reintroduction phase is extremely prolonged because we're not just reintroducing 6 or 8 food groups, we're introducing everything. So that takes a bit of careful planning. And when we do it, we tend to group foods together so that we've got a bit more chance of broadening the diet as well. Also the cost of some of the supplements. So these are quite expensive products. And so, and technically they're not licensed for EoE. So in recent years, I have had a couple of GPs refuse to prescribe them because they technically don't have to, because there's no technical indication under their licensing regulations. And this is just an example of someone, a man I had on an elemental diet who was very active, needed 3,000 calories, 110 grams of protein, and this is what he had to consume in a day. So he had to have 7 cartons of EO28, but 500 ml. These sachets of 500 mils make up to 500 mils each, so 3 of these 500 ml sachets, and then some of the amino acid mix as well, which I have never tasted it, but I'm told it tastes very cardboardy. So I just wanted to finish off before concluding and thinking about how we choose treatments. So in our centre, this is what we have: an allergy review and dietetic assessment. So this is sometimes done by one of the consultants and then referred to me, or sometimes done by just me, because I can order skin prick testing and interpret accordingly. And then following this, we'll think about different treatments. So I'll have a discussion with the person about whether they might want to do dietary elimination, or actually whether diet might not be right for them at this time. And so we might decide that, you know, based on their current diet and their current situation, they're you know, not keen to do diet in the long term, we may say, okay, well, you need, you know, medication would be more suitable for you. And then if they are really keen to go for a dietary intervention, I will talk about the benefits of a 2 food elimination diet versus a 6 food elimination diet. I don't tend to use the 4 food elimination diet. Just, I think 3 steps is too many. So I would start with a 2 food, saying it's got about 40% chance of working, which is small but not negligible. So it's a decent chance, and if it does work, that's great because there's less foods to reintroduce. Or we could do a 6 food elimination diet, which has a much higher chance of success, but is more restrictive and takes longer to reintroduce foods. And then it could just end up being 1 food all along, which is a very long way to get there. And it's really individual what we decide together. So there's no right and wrong answer for any one patient. And then if you have a positive response to the diet, that leads on to reintroduction and identification of food triggers. But if the diet doesn't work, we may revert back to medical management. And then very occasionally, we may use the elemental diet if people are very keen to avoid medical management, or if medical management hasn't worked. And sometimes the elemental diet even doesn't work, which has happened for me once. So in conclusion, so elimination diets for EoE, they do work, not always, but they can work, but they are not right for everybody, and there is no one size fits all. So it's really, we really tailor our approach to the individual. And overall, empirical diets such as 2, 4, and 6 are the preferred approach, and we reserve the elemental diets for very motivated people who've failed other treatments and are really not very keen to use them very often due to all the challenges. And the step-up approach may be preferable for some, but a step-down approach equally it works for other people. And so just to conclude, the choice of treatment, it should be a combined decision between the patient family and their healthcare team, so that you've got the right approach for you, ideally with, you know, appropriate support from a dietitian.
Thank you, Hannah. That was an absolutely fantastic presentation. I don't know how you managed to squeeze all of that into such a short space of time. That was amazing. You've given us a really good overview of the whole picture, and also highlighted on the focused areas what we're looking at tonight with the diet as well. But I think it's important to understand how that all interweaves with all the other aspects of EoE. So we've got a few questions. What I'd like to do now is to bring in Leanne Reeves, who is our other panelist tonight. And Leanne will be giving her talk on our third week for those of you who've signed up. Leanne is, she's joining us now. There you go. We're all on. Excellent. So Leanne comes from the Oxford Foundation NHS Trust. She's also a specialist dietitian in understanding allergy and also inflammatory bowel disease. And so we're very grateful to have her on our panel tonight to help answer questions. And she will also be in one of the breakout rooms when we go through to that. So we're getting a few questions come through now, which is absolutely fantastic. I will start off with a couple of questions that we already had put to us before tonight. So no pressure, guys. So we're ready for some questions if you want to drop us across. So we've got, I think you've answered an awful lot of them in your presentation. I know you mentioned about the gluten, which was one of the questions forever. Always I'm trying to understand the whole gluten-free, what do you cut out wheat. So you've pretty much covered that. If you want to elaborate on it, please do. But I know it's quite a tricky subject to cover from the gluten aspect.
It is, and it's, I mean, I don't think we really know the answer definitively. Like I said, just based on my knowledge of the similarities between the wheat proteins, they're so structurally similar that it makes sense to avoid them all. And also, I would also say that we extend that to avoiding gluten-free wheat as well. So it's wheat with the gluten removed, because we don't know what the proteins are that trigger EoE. So we don't know if there are other proteins still present in wheat, and you can get gluten-free wheat products. There's a few more of them out there at the moment, and that the same goes for like gluten-free beer. It's usually just had the gluten removed. So I normally advise avoiding that as well.
Do you find that it's easier shopping for patients if the indication is that it's to take gluten out when you go to the free for a mile rather than saying just wheat? Do you find it makes it easier for EoE patients to shop?
I think so. I think it does make it a bit of a clearer distinction.
One of the questions that was come up is that as an allergy centre, Hannah, obviously you've mentioned about what pathway you take, but the patients, do they have to be diagnosed before they come to you as an allergy centre? Because obviously the whole situation with diagnosis for EoE, how does that work?
So yeah, most of the patients who come to me specifically in allergy would already have been diagnosed. So most of our patients are referred by our own gastroenterologists or by external gastroenterologists. We work closely with them, but yeah, we don't diagnose patients within allergy.
No, yes, they need obviously they need an endoscope to be able to be diagnosed. Yeah, okay. And also, so I'm just looking through here for the questions to pick up best questions for you. It was an interesting comment, actually. I wonder whether Louisa would like to share a comment, if we can allow Louisa to speak on Spanish data. Can we click, is Louisa in the room to be able to share with her?
Yeah, I'm here.
Hi, would you like to just share with us your comment that you put on there, Louisa?
Yeah, I mean, my comment was, being that I've been diagnosed with EoE myself, and I actually happen to be under Hannah. I'm half Spanish, half English, and I noticed that the data came from Italy and Spain, and that there was quite a high dropout. And I just wondered whether I find personally the challenge of finding free from products over there, and also the type of diet that is followed in Spain, and maybe the hospitality sector not being as open or as advanced in terms of sort of different options on menus, etc. Whether or not that had an impact on a higher dropout rate, and if you did the same study here in the UK, would it maybe be slightly different and maybe a higher, because there seems, for me anyways, my personal perspective, that there's more free from products, there are more varied menus, etc.
I think
it's an observation more than a question, really.
I think that's certainly possible, and another aspect of it could be that in a lot of the Spanish and Italian studies, they don't use dietitians. It's just a diet kind of given out by the clinicians, the doctors, and I wondered if with more like one-on-one tailored support, they might see better retention.
Okay, thank you.
Thanks, Louisa. One of the questions we've got on here as well is about elemental. You've mentioned obviously how tricky it is to use that in a diet. Is it ever used as a supplement when you're restricting 6 or more foods, etc., to keep a balance of the diet? Does it ever get used like that?
Yeah, definitely. Like in our patients who are more restricted or are struggling with weight loss, then we would definitely use it as a supplement. I don't know if you use it much, Leanne.
Not a lot, no. No, I haven't needed to really, and I haven't actually tried it solely, a completely elemental diet with anybody as yet. I'm not sure whether some of my patients, so the patients in Oxford could see, some get referred to me in the allergy clinic, and some would be seen by the gastroenterology specialist dietitian. So we haven't yet really worked out a pathway as to how that's decided as to who goes where yet. That's something that we really need to work on. But so I don't know whether they will have done any.
Yeah. I think that's
any of
a
you
common
find
story.
that there's any other recommended supplements, because that can be quite a challenge for patients. It's one of the comments we've had when they're looking to supplement their diet, when they're restricting it, is finding safe supplements, whether they be milkshakes or feeds, and all sorts of weird and wonderful things get used because people are obviously looking to supplement. Is there anything that you can suggest that people is safe for people to use if they're either 6 or 4 fed diets?
I think it's probably quite variable. It probably depends on the person. I think the nutrients that we tend to see people most deficient in on the diets are things like calcium, things like iodine, but there's no kind of one product that's one fits all. But like I say, everyone's a little bit different.
Yeah, and of course the prescribable drinks, if you're talking about the drinks and trying to get the calories as well, they're all milk-based, bar maybe 1 or 2, which is why we then we're left with those elemental ones. So yeah,
there's not many in the UK. I know some other countries do have various different formulas that are available, but we're a bit stuck really with just that one, and I think the pediatric one gets used sometimes as well.
Yeah, we do. There's one soya-based one now that that doesn't contain the milk protein, so I haven't used it with people with EoE yet, but I have for a few other people, because obviously if milk and soya need to be taken out, which it's likely they will do, then they're not an option. So
and then you are back to the elemental, which, as you say, can be quite tricky for patients to get that prescribed, whether that be at the hospital they're at or by their GP as a continuing prescription. That could be quite a challenge. from that aspect. We've got another question on here. So how do you manage patients who don't have allergies to foods but have a diagnosis of EoE? Do you manage them any differently?
Well, it depends on what you're defining as the allergy then, doesn't it? Because you've got the IgE mediated allergy, which Hannah's talked about. So that's the immediate type of an allergy. But what we're trying to work out with the elimination diets is whether one of those or one or more of those foods you do have a non-IgE mediated allergy, is what we call it, that's driving the inflammation and causing the EoE. So yeah, that's trying to understand the definition of allergy, I think. And so you may not have any positive testing. If you do have any allergy testing, they could all be negative, but there still could be foods. So particularly any of those top 6 that Hannah's talked about that could be driving the inflammation.
And they're used to class a lot as hypersensitivities, aren't they? You know, the delayed reaction or intolerance, I suppose. Some people use the word intolerance instead of allergies. It gets quite confusing.
It does get confusing, and the sort of the umbrella term would be the hypersensitivity, and then within that you've got the differences between immune mediated, so that's the IgE or non-IgE, and then you've got intolerances that don't involve the immune system. But in this case, we're talking about non-IgE immune mediated allergy.
And I think sometimes people struggle to understand when we say non-immediate, how long it actually means before you could have that reaction. I know Hannah said, you know, when you reintroduce the food, to actually see the effects on your EoE can be quite a considerable amount of time in weeks. But actually, even if you have an intolerance and a mild reaction to something, what would you say, a week? It can happen within a week. You have a sensitivity to something if it's a non-immediate allergy. You know, even if it isn't an EoE response, if it's just an intolerance.
Yeah, typically would be within 48 hours.
Yeah. Thank you. So I'm looking at so we've got one question here as well, which is quite interesting. Do you know, somebody's asked a question about the string test, which is obviously bringing us into the whole allergy and the future side of things. Do you know if the string version of the testing for looking for EoE samples is actually brought into any of the other hospitals other than Southampton was the question. So do you know, is it being used in Guy's and St Thomas's at the moment?
No, we don't use it. It's still very much in the research field, and it's not validated yet. It's very promising, and there's also the other approaches like the cytosponge that all look very exciting and potential, because we all, you know, we would love to have an alternative to endoscopy as well, because we know it's not pleasant. But yeah, that's the future. We're not there yet.
Absolutely. The gold standard is still to have to take the biopsies to look to see exactly what's happening on the inside and look under a microscope. Unfortunately, it will change. And someone's also asked about the transnasal testing, which again is another area that's being looked at for the future.
Yeah, we do transnasal at Guy's and St Thomas's.
Excellent. And that's done routinely, is it, for EoE patients now?
Yeah. I mean, Dr. Dunn recommends doing it like for all EoE patients who are happy to go for it, because it's it's his preferred method. Yeah,
well, it saves having to be sedated. It's not so long-winded.
But it is not right for everybody. I know I have a couple of people who really didn't like it, didn't get on with it.
Somebody's asked a question about when you said about reintroducing foods in groups when you've eliminated an awful lot out. What sort of groups are you talking about? Someone's asked.
Yeah, so it really depends on what approach we've taken. So if we're talking about like an elemental diet, I tend to try and get together a group of 10 foods that are safe foods, that are very low risk to introduce for the first round, and that we can hopefully build on. And if that's fine, introduce 5 to 10 more foods, and before moving on to like more higher risk foods individually later on, for an elemental diet. Sometimes if we're transitioning from a 6-food elimination diet, we might introduce some of the low risk foods in groups of 2, sometimes together, but mostly separate. So we might introduce, say, nuts for 3 weeks and then fish for 3 weeks, and then group those together for an endoscopy.
So Leanne, would you say if someone has already got, or Hannah, an allergy, known allergy to something, I mean, you would hope that they're avoiding it anyway, even if it's a delayed response. But would you say that that's a good starting point? You know, if they've had a reaction to something in particular, then that food group would be a good thing to avoid, especially if it's in the top 6 when they're looking to cut out foods for their EoE diet. I think they're talking about fish in this instance, so it's not had an anaphylactic reaction, but you're talking about sickness. So with that, then I mean, I know fish can be in that group, and there's a lot of anomalies around the shellfish and fish, depending on what country you're in. But would you say that then you'd sort of take the focus away from milk and wheat and say, well, actually, if you're already allergic to fish, then you probably should cut that out as your first one?
I'd say they should probably be avoiding it anyway. But whether it's driving the EoE or not is another matter. So I think you've still got to investigate the other foods. Yep. You know, I think that fish is probably one of the lower or less likely. I can't remember the figures on that, Hannah.
Yeah, it's pretty low, but we do. Well, I have seen it, so it does happen, but it's not the most common by far.
Excellent. Okay, well, what we're going to do now is give everybody an opportunity. We're going to split out into some smaller groups.